Okay, this is a case from Cookie. So what do you think here? Here's a coronal MRI, and they give you the axials. So this is the uterus here. There's a bladder here.
I see something in the kind of corneal interstitial area right there.
Yes, good. Let me give you the axials.
And I see that there's a T1 hyperintense focus in the middle of it.
Yes, yes. So this is the area, this thing.
Yep.
And then that corresponds to the T1 hyperintensity.
Okay. So initially when I saw the T1 hyperintensity, I was thinking endometriosis, but that rounded look in the interstitium here, I'm worried about an ectopic that has hemorrhage.
Okay, HCG is negative.
Oh.
Yeah.
HCG is negative. Okay.
Yeah.
Could endometriosis look like that? It does have shading. It's like T2 bright. Oh no, wait.
Yeah. No, it's it does
T1
have
bright and then gets
yes.
darker on T2.
Yes. Yeah. So there's blood. This is blood. Good.
It doesn't like, I guess, I don't know, it's like focal adenomyoma, but that is kind of separate from the endometrium.
Yeah.
That's all I got.
All right. So this is an accessory and cavitated uterine mass. ACUM.
Okay. What, tell us more.
So it's like a separate uterus, but it's completely closed off. So I'm gonna.
Oh, is it kind of like a rudimentary horn?
Yes.
But the rest of the uterus looked normal. So I wasn't thinking like unicornua with uterine horn.
No. It's a separate. It is a developmental anomaly. So it is rare and newly recognized. So I don't think it, like any of the, if you Google it, it's not going to include that in the kind of the old classification. So it has functional endometrium. So that's what T1 hyperintensity was. And in contrast to other in which the uterus is malformed. Okay. So it looks like a normal uterine cavity, right? The cavitated mass is defined to the myometrium. So the cavity itself is the endometrium.
Adenomyosis, where
correct.
Yeah,
that's right, and it's encapsulated, right? So it's completely closed off and encapsulated, and it looks like a uterus. Unlike adenomyoma, which is more like cystic looking, T2 hyperintense. So let's go back to the imaging because it meets all that criteria. So this is the endometrium, right? And that has a blood products, and this is a junctional zone equivalent, and this is a myometrium. But it's completely
that's really cool.
Closed off. So so it can cause menstrual or pain with menstruation. And here, let me see. Let me go back to this thing. Yeah, so I think MR is probably better than ultrasound in the diagnosis of it. And you can resect it so that you could treat the patient's pain and symptoms.
Very cool.
So again, a case shared by Cookie.
And I see Arkansas has joined. Who is there?
Oh, hey, Aarti. Nelly, this is Kedar. Rupa is here.
Awesome.
Okay, so this is a patient with a history of a liver lesion. No history of hepatitis or Hep B or anything like that. So here's your T2, and here are your dynamics. It's 2.5, and then we have a 20-minute here, or actually give it 5 minutes. So the lesion of interest is here, right there, just to direct you here. So on T2, it's kind of like ISO-ish. On the EVIST, I'm sorry, this is the 5-minute delay phase, but on that you see this little kind of subtle thing. And then I'll tell you it's a little bit easier to see on, here's the subtraction. So here it is, this.
Show me the T2 again. And also, was there any
Yes.
of this phase?
Here's your T2. T2 is kind of like intermediate to high, ISO, intermediate, yeah, maybe a little bit intermediate. I don't know, I can kind of hallucinate it, intermediate. And then EVIS is here and it's here.
Okay, so everything about this except for the arterial phase is making me think FNH because
Okay.
it's ISO on T2, delayed, and there's a lot of retention on the EVIS except for that one small area. But the larger lesion is mostly retaining.
And
So
yeah, I mean,
I would have thought about an atypical FNH that just doesn't have as much robust arterial enhancement.
Yeah, that's like that's a really good thought. So this was pleosis, hepatic pleosis.
You mean peliosis?
Peliosis, sorry.
Oh,
and let me
wow.
pull up the biopsy proven pleosis, and I'm going to pull up the paper, or actually, I'm just trying to find a good paper online, but probably Radiopedia had the best one. Could not find a radiographics paper on hepatic peliosis. It's a vascular sinusoidal. It's a vasculation. That's what it is. So you get this sinusoidal dilatation, and so you can get this kind of higher T2 intermediate signal because of the blood, blood-filled spaces. And there's a lot of different causes of it. Here's some causes. And I think it's a hard diagnosis to make personally. So they can be bright on T2 because of the vascular filled spaces, and enhancement is typical, usually centrifugal from center and going outward. This one doesn't really meet that criteria. I think the enhancement is kind of iffy. If any, here it is, but there's central enhancement. Does it do centrifugal? Let's see. So we have, so let me move this one arterial there, and I'll give you 60 seconds and 2.5 minutes. So it goes from the inside out, and then the 5 minutes is here. So I don't really think.
I mean, I think I would have just called that like delayed enhancement. It's not as much like so defined.
Yeah.
Like I would have called it prospectively centrifugal.
Yeah, I don't think this really is a good classic typical appearance of hepatic peliosis, but it's something to consider because it's and like I said, something that I think it's hard for me to diagnose or put that in the differential. I mean, I'm still trying to get my head around it, but here's a good example from Radiopedia. Like I said, I couldn't find a good radiographics paper, but here, so ours did have that T2 bright, areas of sinusoidal distension dilatation. And then, so that's your T2. This is your here's your, I don't know. I don't think this is also inside out. This is really outside in, if anything, unless I misread the paper, but, and then here it is. Okay, so hepatic peliosis.
Nelly, going back to your Radiopedia, the original article, you can see that it's listed as like there's tons of things that are related to it. So I often think of it as something people see in HIV with like the the Bartonella infection, or related to OCPs or chemotherapy and stuff. So did your patient have any risk factors? Like, did you relate it to any of these diseases?
No, that's a good question. Let me see if I can, let me stop my share and see if I can get a history that has any of that. Not that I'm aware of. But I didn't really dig in, to be honest. I don't know if the patient was on OCP or something else.
So basically,
but pathology was
incidental
compatible.
Lesion, they biopsied it, came back peliosis, and then they're like, we're just going to leave it.
Yes.
Cool.
Yes. Yeah. And I did have a companion case for the hepatic peliosis, but I'll share that next time because I don't think the images are that great either. Like it's not classic.
You can bring it up if you want. I can pause. Hold on. Okay, go ahead, Rupa.
No, I just said the peliosis was hard because it looked triangular, almost wedge shaped. It looked like vessels going through, sometimes like how you see with focal fatty sparing or infiltration. Except I guess on the T2s, it's a little intermediate, right? Like it looks like a lesion, not liver on the T2. So it was a tricky one, I think. And I was
Yeah, I
also
don't
going to
think
ask about risk
any-
factors.
Yeah, I don't think anyone would have called this prospectively.
Prospectively.
They were like, the patient has HIV, you know.
Right.
And I don't know that I have a good grasp of it yet still either.
We've occasionally raised it when there are multiple weird lesions in a patient with HIV and we just don't have any other explanation and they kind of look blobby and sort of like what Rupa said, they have vessels crossing them. So you're like, it's something, it's like liver, it's not a true mass, but there's some process going on in that part of the liver. So we have occasionally raised it. I could also see why it would be difficult to be path proven because it could just look like broken down sinusoids, you know, and I don't know how they would get the like true diagnosis unless they got like a, you know, a gross specimen. So yeah, I think it's a challenging one. Okay, so this patient was having pelvic pain and they did an ultrasound. And you can see that there are some calcified fibroids, so echogenic with a lot of posterior shadowing. So it just looks like a calcified thing in the uterus, which we would presume is a fibroid. Another calcified fibroid right there. So there were several calcified fibroids, and then there was this thing, and it looked like it was actually in the uterus, this bright thing. And there it is. It's kind of like got a claw sign with the myometrium. But a part of it also extended beyond the uterus.
Very
So,
echoic, like hyperechoic.
yep.
Thinking fat, but
Yeah,
we'll
good
see.
thought. And then this was the cine through the uterus. So you can see that it's very echogenic and it goes outside of the uterus as well. So thinking fat, often when we think about fat in the, like on a pelvic ultrasound, we think about a dermoid. But anyway, this was the MRI for this patient. And I'll just tell you that this was the lesion. I'll show you the high res too. So this is the high res.
It's not like a clean fat.
It is, it's like a weird.
And does it sat out like fat sat? Like, does it sat out? So is it really fat or is it like a myxoid lesion that's T2 hyperintense?
Okay, excellent questions and points. But like the other interesting part to me is like, it looked like almost like it has a stalk. Like it's arising from the myometrium, but then it goes like outside of the uterus and it's kind of exophytic out here. So
like, I'm thinking like sarcomas, like some kind of sarcoma. It could be like a liposarcoma. It could be, I mean, but I need to know if it's a fat or if it's not fat. Is it fat?
Okay, so here's the T2 without fat sat. And then here's the T2 with
Oh,
fat.
so it's fat.
Yep.
Aarti, it's not of ovarian origin, right?
No, it was arising from the uterus.
So like
Liposarcoma.
a lipoleiomyoma that herniated out?
Exactly. So this
But
was,
how do you like exclude liposarcoma or something? Like it's so dirty. Like it's complex internally.
that's true. We I have not seen a liposarcoma arising from the actual uterus.
Also, I think Aarti, in this case, the ultrasound helps to show that it's actually connected to the myometrium, right?
Yeah. And both the MRI and the ultrasound, we felt confident that it was like really arising from the myometrium. So we called this a lipoleiomyoma that like had an exophytic part. I think, you know, leiomyomas can be complex, like fibroids can be complex, can look like this, even like the myxoid, you know, fibroids can look like this. So we just called that a lipoleiomyoma. I'll show you the post contrast if you're. So I guess, Nelly, you're right. Technically, you can't, any fatty thing, I guess you can't exclude a liposarcoma, and you're saying it looks like a little bit too complex. We were kind of favoring that fibroids are more common. It's arising from the myometrium. Fibroids can look complex, and so we called it the lipoleiomyoma.
This was the other companion case where we raised hepatic peliosis. No, we don't have path because it's just being surveyed. This is the T2. These lesions are multifocal. Prior biopsy was benign. Let me just double check that that was the case. Let me see. Actually, I take that back. I'm not sure if we had a prior biopsy. I feel like we should have. And I vaguely remember we did. So this is the arterial phase, and this is more of, I guess, what we were learning earlier from the Radiopedia article about centrifugal. It starts center and then goes outside. It's sinusoidal dilatation or spaces, so maybe that explains the T2 intermediate signal here. I want it to be more bright like this, like the other cases. Here it looks more evil gray than, cystic. But
go to the I love this, that it really is filling from the inside out. And then if you go to the delayed,
yes,
really don't look like true masses, like kind of like Rupa was pointing out before, like it almost looks like that big one posteriorly almost looks like it has vessels going through it.
Here, this is a vessel. There's maybe this one.
And
maybe,
and even smaller vessels going through other parts of it. So
like
I love,
one.
I really do like this for peliosis. And then the question is, what's their history? It looks like they have chronic liver disease. So
they do. They have cryptogenic cirrhosis.
So do you have to LIRADS this? Can you LIRADS?
Can you LIRAD cryptogenic cirrhosis? Is that
I don't know. If they have known cirrhosis that's not
proven cirrhosis,
congestive, then yes.
Yes.
So those, that's there. Hepatic peliosis.
I think if you did LIRADS it, you would have some AFI, no washout, no capsule. So at most,
but it wouldn't qualify for the AFI because it's not homogeneously enhancing, right? Like here, it's the central part that's enhancing.
Does it have to be homogeneous? I mean, you can have HTCs
so.
with a lot of heterogeneity.
But
I see what you're saying. Like if it's just central like this, does that qualify?
Yeah, I don't think this meets criteria for AFI, but we need Victoria to confirm.
Yeah. Okay.
This is a patient with stable findings in the bowel wall.
I see pneumatosis, but like almost bubbly pneumatosis.
Yes.
Like
so
pneumatosis cystoides.
Yep, exactly. So I will tell you, we have 2 studies that are 2 years apart. This was the 2-year study that was 2 years earlier. And we see free air. There's, benign there's free air here, little air bubbles there, big blebs here of air under the transverse intestine colon.
It still looks like a benign thing, like you said, 2 years. And I feel like we should have a new term for free air, because free air, everybody gets super concerned. But if you have benign pneumatosis, it can dissect into the pericolonic space. So that should just be called like benign extraluminal air.
I like that.
You heard
I
it
think that
here
makes it very
first.
clear. Huh?
I said you heard it here first. I literally just made that up.
But it makes it clear this is not life-threatening free air from perf.
Yeah.
And so, I mean, words matter, right? And I think this is so. Anyways, here is a paper from AJR describing this pneumatosis intestinalis as pneumatosis cystoides intestinalis. And you get these air bubbles, within the wall. So here are some nice examples of that. And this patient has had these things for multiple years. So it's benign. And I think it's idiopathic. Like there's different, like there's not one, 85% is idiopathic. Yeah.
And
So
you only use that term pneumatosis cystoides intestinalis when it's like this benign, bubbly kind of thing, right?
I think so. I like we have follow-up, so I think we can comfortably call it that. Pneumatosis cystoides intestinalis. I think if it's a like initial evaluation, I don't know if we can label it that, you know, and say it's definitely benign. I don't know. Can you like upfront just call it that based on a
No, I'm
single
just
time
saying
point?
like this paper doesn't even say cystoides in the name. I think like for me, cystoides is that benign version. They have some kind of connective tissue disorder. They tend to dissect air into their wall. It tends to be more bubbly. You can see it on multiple exams. It's like a totally benign thing.
Mm-hmm.
And then there's other causes of benign pneumatosis intestinalis, which is like steroid use, chemotherapy, asthma, blah, blah, blah. And then in the colon, especially, then a smaller percentage is going to be like true like ischemia.
Yeah, so here's an example of that. Like this looks like this article goes to the breast, so it's not specific, sorry, for cystoides intestinalis. Like there's other, it's more of a review paper. And one of them is pneumatosis cystoides intestinalis. And I like that. Yeah, like it is more bubbly, right? Like I think example we had earlier was yeah, bubbly pneumatosis intestinalis, but it's very big bubbles. Like ours was very bubbly also. This one is from chemotherapy, and I don't think it's as bubbly. We see air, but it's a lot more kind of dissecting through the interstitium rather than big bubbles and blebs.
Yeah, and I always tell my residents, like, because people will be like, oh my God, there's free air. That means there's a perforation. And it doesn't necessarily mean there's a perforation because air can dissect through planes. It can go through fascial planes. It can go, it can go through the wall, and it doesn't necessarily mean that the bowel has perforated.
I think that maybe benign pneumatosis versus non-benign. So the non-benign one where we do have to worry, I remember one of the residents, Cameron Adler, who's now faculty with us, he mentioned he did a research project in separating the benign from the non-benign pneumatosis. And what he told me was if there is free fluid, if you start to see mesenteric edema, fluid, like portovenous gas, then that suggests more non-benign causes like ischemia compared to our case where we don't see any of that, right? I mean, everything's like so clean and like, yeah, there's no mesenteric edema, there's no free fluid, there's no mesenteric gas, portovenous gas, anything like that. So
yeah, I've had a lot of patients in the oncology clinic where I'm like, oh my God, there's diffuse pneumatosis. And I call the oncologist and they're like, patient is absolutely fine. We treat the patient, not the scan. And then like the next scan, they still have pneumatosis. I'm like, oh, that was a benign thing. So, a lot of chemotherapies and steroids can also cause it. So I have a actually good companion case. Okay, so this is my case. It's a companion case. You can see that there's also a lot of large masses. This patient actually had a dedifferentiated liposarcoma of their leg with metastatic disease to the abdomen, including the liver, the portal hilum, actually also lung mets. When sarcoma mets, it likes to give you rounded, like kind of hematogenous mets to the lungs. But the other incidental-ish finding was that there was pneumatosis of their esophagus and of the entire stomach here. And so when we talk about gastric pneumatosis, people kind of talk about it in a slightly different way, and they often call it gastric emphysema. And there are a couple of different causes. So you can have emphysematous gastritis, which is usually like a gas-forming organism in the wall, very morbid. And then you can have ischemic pneumatosis, like the same thing we talk about the bowel. And then you can just have gastric emphysema, which is actually the most common cause. And if you think about it, a lot of times we're putting NG tubes in patients and kind of like shoving it down into their stomach repeatedly. And so the most common cause of gastric emphysema is actually trauma from an NG tube. So, the NG tube shears the mucosa, some of the air dissects into the wall and can dissect diffusely. This patient actually, like we called them, we're like, oh my God, they have diffuse, I don't know at this point if you're going to call it pneumatosis or emphysema or what, but they have, and it's even going into their esophagus. And they said, the patient's stable. And then the patient actually did fine. And I do have a follow-up CT that basically shows that they're essentially resolving. This is a follow-up CT like a week later, and you can see their stomach is basically back to normal. They still have all their big masses and stuff. So that was just a benign gastric emphysema from a mucosal injury. I don't know if it was related to an NG tube or just some other kind of injury from maybe the tumor, etc. So yeah, even when it's really diffuse, it can be benign. Go.
Okay. This is an outside CT.
Male patient?
Mm-hmm.
Okay, so massive. Well, the prostate looks separate. I see the prostate down there, and I see a large pelvic mass that's touching the prostate. If you go up, Nelly, I feel like I see the prostate right there. So it's either exophytic from the prostate or just touching the prostate. It's also touching the sigmoid colon and rectum. So like GIST is in the differential, or some kind of mesenchymal tumor arising from the prostate or seminal vesicle.
Excellent. Excellent. Yes, that's right. So we didn't, I mean, you know, we all make mistakes. This was read by outside as a prostate mass. We only have these images in retrospect. And so the patient went for a HoLEP. And during the HoLEP, what?
What's a HoLEP?
Oh, it's like where they basically do like a transurethral resection of the prostate.
Okay, so it's like
Here, let me bring it up. Yeah, we do a lot of those here. Let's go HoLEP, holmium laser enucleation of the prostate. It's like a prostatectomy, transurethral version.
Oh wow, cool.
It's amazing, actually. Like, I mean, it's used for treatment of BPH, and they our urologists go in and essentially enucleate the prostate transurethral.
And what is that white stuff there? Oh, that's like the stuff they're enucleating.
Yeah. So
Okay.
That's the vapor, and they just vapor. I mean, they just like, I think that's the vapor. So here, it's like if you have the prostate, they just go in and enucleate it. You know, this is a nice cartoon picture of that process.
Got it.
So yeah, the patient had a went in for a HoLEP, and during the HoLEP is like the mass is extraprostatic, not intraprostatic. So I think, you know, it could be hard, and I think sagittals are really helpful. I find sagittals to be very helpful for the pelvis to make sure that we have the mass coming from the right organs and structures, right? So here we see the prostate. If you follow the bladder, prostate is here, and then that goes into the bulbous the penis, yeah. So the patient did have an MR, and the MRI, this was after part of the resection, and the pathology from the HoLEP specimen, well, this was hemorrhage after the procedure, but it was a fibrous tumor. This is a fibrous tumor. So
of what? Of like the seminal vesicle, or just
it just says pelvic solitary fibrous tumor.
Oh, solitary fibrous tumor. Cool. Sorry. Very cool.
Yeah. So just, you know, clarify the anatomy, make sure we're, you know, saying is, you know, if it's indeed prostate, that it is coming from the prostate and not just squishing it. That was a hard study because there's no IV contrast or anything like that. So you're going off of a non-con study.
Can you show on the MR if you have any axial T2 and post contrast?
Yeah, so here, axial T2.
Just to show the relationship with the prostate, just out of curiosity.
Sure. Here's the axial T2. The prostate is here.
Mm-hmm. Yeah, so it does look separate.
Yeah. And then post contrast is here. That's a really good post, 60 seconds, but here's the prostate, and then the mass is here.
Yeah, pretty moderately enhancing. I'm sure the top part is blood, but
yeah, the top part is blood. It's like hyper intense on T1, and it has mass effect on the posterior bladder wall.
I feel like this overlaps with like other lesions we've seen. See how it like has that multicystic appearance with like the giant adenofibromas of the seminal vesicle or the prostate, and also like stump tumors and stuff. But
yes, when I saw this, I thought it was a cystadenoma. But you're right,
Yeah.
there's lots of overlap, right?
But if we had gotten an MR, I think we would have said, one, probably exophytic from the prostate, and two, probably a benign lesion, although they're going to resect this kind of thing anyway. But yeah, very, very interesting. At this point, MR is so much better.
Oh my gosh, yeah.
Yeah.
I don't think on the MR we could have called it a solitary fibrous tumor. They typically don't look like this.
Not multicystic like that. Yeah, they look more usually like spindly.
And they show, you know, uniform enhancement.
Yeah.
We have a couple of those in the pelvis, so this looks very different.
Yep. It's interesting also that they thought they could resect that massive mass through using a HoLEP.
Well, if this was indeed a large prostate, they can do it. And
Right.
they've done it. Like
That big?
Yeah, they've done HoLEP on like 250, 300 cc prostates. It's an amazing procedure and it's very effective. Yeah, so it's not the limitation of the procedure itself.
Right. But if it's a mass and it's exophytic like that, it seems like then sarcomas in the differential and stuff too.
Yes, for sure. Yes.
Okay.